Okay. Hello, Deliverable 5. Today I'm going to be talking a little bit about a 18-year-old female. She came in with abnormal uterine abdominal bleeding and iron deficiency anemia. It was a little bit challenging because it required balancing some symptom control with long-term reproductive health and patient-centered care of a very young woman who is not sexually active as of yet. However, we did rule out pregnancy first, of course. And this patient presented with heavy periods. She says her menses is irregular. She's got this constant fatigue. And her labs did show some iron deficiency anemia. We did rule out pregnancy and thyroid dysfunctioning and bleeding disorders, coagulation studies, and those were negative. So most likely her diagnosis was involuntary abnormal uterine bleeding. Our first pharmacological management is going to be prioritization of combined oral contraceptives as a first line for therapy. And we basically ruled out the pregnancy first and addressed the underlying evolution of regular cycles and reduced menstrual in hopes of significantly reducing her menstrual blood loss. So that's why that seemed to be the best of treatment options, especially with our first priority. And then again, our second priority is going to be looking at her hemoglobin, which is a little on the lower end, and she is symptomatic. So of course we wanted to assist that appropriately. And we did put her on some iron supplementation due to her symptomatic anemia to correct that lower hemoglobin, not just for her physical health, but also for, cognitive performance, daily functioning concerns. Lastly, we did want to put her on some NSAIDs or increase her utilization of them. She was taking them, but not on a regular basis. And we just did some education with helping her understand that it's just not for an analgesic effect, but also it helps that prostaglandin mediated bleeding and also some of her inflammatory concerns. And then finally, we did give her some tranexamic acid as a secondary option for her heavy bleeding and her breakthrough bleeding. Although, of course, this is not first line of defense because we do not want her taking this regularly. The max is 5 days on it. If she absolutely needs it, which she understands, she's going to do that because of the risk, of course, for blood clots and thrombosis. So that is the medication piece of it. So the non-pharmacological interventions that I prioritized, she's a younger gal, so she's borderline adolescent, right at 18. So we talked a little bit about misconceptions about bleeding, menstrual health, and hormonal therapy, ensuring that she understands and will be compliant, not smoking because of blood clots and so forth. She did really good on that. And then we also talked about dietary support to try to get that anemia recovered a bit, and journaling because she finds that some days are worse than others. So we are going to have her journal for the next 6 to 8 weeks. And then when she comes back, we're going to look at that. And then lastly, we trying to think what else do we do? Oh, heating pad. We're having her use a heating pad 20 minutes on and 20 minutes off on her significantly pain and heavy days, just to help her relax and hopefully find some therapeutic care there as well. So again, it was a good case because we had to use both the pharmacological pieces, even though they were relatively simple, along with the non-pharmacological pieces to really focus in on the patient-centered care because she is adolescent, right at 18, just turned 18. So hopefully that combination will help her. Thank you.